Hello, and welcome to the lecture about transpulmonary pressure. And we're going to be specifically looking at patients that have ARDS, acute respiratory distress syndrome. And so when we're looking at transpulmonary pressure, it's different. Previously, when we looked at managing mechanical ventilation, we looked at the difference of the plateau pressure as well as looking at the difference of tidal volume and how those related to survivability on those patients. However, the study that came out in 2015 and subsequent studies that are looking at this as well are looking at the difference between plateau and PEEP and looking at that as strain on the lungs. So that's what this lecture will be talking about, is that study, what is transpulmonary pressure, and how to see it on our patients. So these are going to be our objectives. So what is driving pressure? The impact of driving pressure on acute respiratory distress syndrome. They'll look at independent variables and how they impact the outcome and how they determine that driving pressure was the big thing. To look at validation on a prediction model and then the test. And so when we're looking at this, it's important that we look at improving outcomes in our patients, especially in critical conditions like ARDS. So a model like this that this study used, the Amato 2015 study, really was very heavily reliable on selecting independent variables to look at survivability and look at interventions that would help survivability. So I want to look at the impact of driving pressure on survival in ARDS, as well as the role of independent variables in predictive modeling. So we can look at these good models to enhance our patient outcomes. Driving pressure is a critical concept in mechanical ventilation. It represents the pressure difference between plateau and PEEP, that positive end expiratory pressure. And what we're looking at with that gradient is the amount of pressure that's applied to the very sensitive parts of the lungs, that simple squamous that's in the respiratory zone. And so that very, very simple tissue that's sensitive and very prone to destruction if we overinflate or if we have atelectatic trauma and underinflation, then that can lead to a lot of trauma on the lungs. So pretty much we're looking at an alternative version here is the change in tidal volume equals the change in respiratory compliance, that lung compliance. And so when we look at driving pressure, it's an essential thing to optimize ventilator settings to reduce or minimize lung injury, particularly in situations like ARDS. So looking at that as your driving pressure, the difference or that gradient between the plateau and the PEEP is pretty crucial in understanding what's happening to the lungs. So here's a picture of what's happening to the lungs. So let's talk about what ARDS pathology is to begin with. ARDS is triggered by an infection, a trauma, a pneumonia that will cause inflammation and swelling. Well, when this happens, that inflammation and swelling happens, fluid will leak into the alveoli, the respiratory zone part of the lungs, and when this happens, that respiratory zone becomes very stiff because of the swelling and the inflammation that's going on in there. As a result, the alveoli will collapse as they lack surfactant, and atelectasis will reduce the ability to exchange oxygen and CO2. So your body is going to become more hypoxic and you're going to retain more CO2 in your bloodstream. This is not a good thing ultimately for the patient as their pH becomes lower and lower. Obviously, hypoxemia will be a subsequent cause of all this that will harm the organs. This is where the kidneys, the liver, the heart will start to have issues here because they're not getting the oxygen levels that they need. And ultimately, too, ARDS can cause scarring and long-term fibrosis changes. So when we're looking at the pathology of ARDS, it's a pretty significant pathology. So when we look at mechanical ventilation, we want to lower airway pressures to avoid that stress and strain and inflammation. So that's keeping the plateau pressure low because it is the plateau pressure that really represents the alveolar pressure, the pressure that gets put on the very sensitive parts on the lungs. So using smaller tidal volumes, using smaller airway pressures, using PEEPs that are appropriate to maintain the lungs in a healthy recruited state but not over-recruited state have been associated with survival benefits by a lot of randomized clinical trials. that involve patients that have ARDS. There are different components of lung protection in those strategies. Lower tidal volumes was the classic one. The one that came out in the 90s with the ARDSnet study was comparing 6 ml per kilo tidal volumes to 12 ml per kilo of predicted body weight tidal volumes. And obviously the lower tidal volume group had lower plateau pressures, and they had better survivability. So they had to end that study early because of the ethics involved with it, of not allowing those patients to have higher tidal volumes anymore. So lower plateau pressures and higher PEEPs can reduce mechanical stress on the lung, which are thought to cause ventilator-induced lung injury. So if we give someone really big breaths, or PEEPs that are way too high, or PEEPs that are not adequate to maintain the recruitment from the swollen respiratory zone, can cause trauma and damage. And so when we're looking at all these different components, what do we follow? What's the survivability? Do I just do a low tidal volume strategy? Do I use a high PEEP strategy? Do I use a low PEEP strategy? How do I know what's going to help my patient survive the most? Well, the big thing here is understanding, for instance, PEEP can increase plateau pressure, which could even drive driving pressure even higher with unknown consequences. So when we look at this situation, it can be a little confusing. Well, what do I do that helps minimize stress on the lungs to help support healing and recovering, but at the same time allowing for gas exchange to happen so our organs stay alive? So to minimize ventilator-induced lung injury, most studies have scaled tidal volume by predicted body weight to normalize tidal volume to the lung size. However, with patients that have ARDS, the portion of the lung that's available for ventilation, that respiratory zone, is a lot smaller because of the swelling, because of the edema, because of the weight that's going on down there. They're going to have a lower compliance. They're going to have high elasticity. And if we give them a normal tidal volume like you and I, when their lungs are really, really sick, we could actually be causing biotrauma and ventilator-induced lung injury. So looking at the tidal volume to respiratory compliance, we're looking at the functional size of the lung. That would provide a better predictor of outcomes of patients with ARDS than just using tidal volume based upon a normal, healthy adult lung. So we've got to look at what is the size of their lung currently. Not what the size of their lung is when it's healthy, but what is the size of the lung when in its current sick state? And how do we get a tidal volume or a change of pressures, change of volumes that are appropriate for that level of lung that doesn't cause it to be worse? And that's where looking at driving pressure comes in. So it's the plateau minus PEEP. And what we're looking here is at these very small parts of the lung. All right, so here are some graphics. Here's just a ventilator graphic, and as we're looking at the breath being delivered, here we have the PEEP, that baseline level that's down here, and that level is just hanging out to maintain somewhat parts of the lungs. But even at this level, are there parts of the lung units that are too small? Absolutely, that are still collapsed. And when we see sick lungs, we're going to have those lung units that are collapsed. And as we're delivering the breath, as this breath is going up, it's taking more pressure to inflate this. Just like those brand new balloons, when you pull them out of a package and you try to blow them up, they're going to be hard to blow up at first, right? And then you're going to have to overcome all that pressure to open up that balloon, to stretch it out, to get it to open up. And all that pressure you took to overcome that balloon to stretch it out would be your peak inspiratory pressure, how much pressure it took just to get it open. But that doesn't represent how much it takes to maintain it. That's the pressure it takes to open it up. And once we have it open, once we give that balloon all the way open, the pressure we need to maintain it isn't usually quite as much. And so that's when we're looking at this. I want to look at if we do an inspiratory pause, which is what we see here with the plateau, and we separate that from how much PEEP they get, this area here is looking at their driving pressure, how much pressure it takes just to get the respiratory zone open, because the PIP includes airway resistance, which would be conducting zone. That would be edema or secretions in your trachea, your main stem bronchi, if I had a foreign body obstruction, if I had bronchospasm, all that would be airway resistance. I'm not looking at the conducting zone. I'm looking at the very sensitive parts of the lungs that expand when you're breathing. That's the respiratory zone, and that's the plateau pressure. So peak inspiratory pressure minus plateau, that's looking at raw, that's looking at air resistance, that's looking at large airways. That's not what I'm looking at here. I want to look at the very sensitive parts of the lungs to make sure I don't destroy those, and that's the plateau minus PEEP. So that's the small parts of the airways. So further graphics here. When we're looking at this, I need to look at the pressure due to pulmonary compliance, right? I'm trying to look at the very sensitive parts of the airway here. And so I need to do that inspiratory pause maneuver on the ventilator, hold it, get that elasticity, that recoil, and look at the gradient between the plateau pressure minus my PEEP. The bigger the gradient is, usually the lower the compliance is as well. And that big gradient can cause ventilator-induced lung injury and biotrauma and make the situation worse for the patient. So the ideal situation here is to still make sure we keep our plateau pressures under 30 centimeters of water, but make sure that our change of pressure, our driving pressure, the difference between plateau minus PEEP, is at least 15 centimeters of water or less. So using strategies that help reduce driving pressure as well as keep our plateau pressures under 30 is the ideal situation. Why a plateau pressure under 30? Well, the plateau pressure above 30 impedes capillaries, and not only can it cause an issue with shunting when you have ARDS, but now you're looking at, if I do too much pressure and too much plateau pressure, I'm actually also now causing a dead space or a reduced perfusion, so I can exchange CO2 and O2. That's why with some patients with high plateau pressures that are above 30, not only can you get the capillaries being crushed, but also you can cause even more barotrauma and pressure trauma to the alveoli as well. All right, so this slide is a little bit more direct. Here is the driving pressure. Here's what we're targeting. We're trying to keep this at or below 15. So when you're in front of a ventilator, you're going to do that inspiratory pause maneuver, and then you're going to hold it, and then you're going to look at your gradient. That gradient between plateau pressure and PEEP is your driving pressure. So the PIP and plateau, if that keeps going up, you know it's an air resistance, large airway issue, maybe bronchodilators, maybe secretion management, maybe something like that is going on. However, if it's your driving pressure that's changing, usually it means your compliance is changing. It could be positional. It could be a situation where their abdomen chest wall is becoming less compliant, like an edema or an effusion that's going on. So those are some things to think about here, but it is the driving pressure that we're looking at to look at the stress and strain on the very sensitive parts of the airways. All right, here's an example of driving pressure. And so what we see here is the driving pressure in this image. Right here is the plateau minus the PEEP, represented right here. And so when we're looking at this, when we do that inspiratory pause maneuver, when you see this, we have a PEEP set roughly around 8 and a plateau around 18. So it's the gradient between the two that would be our driving pressure. That's what we're looking at here. So if you were to go in front of a ventilator, do that inspiratory pause maneuver, get a good value where there's not respiratory motion, right? So the patient isn't moving. So make sure it's a good effort, good recordable values, and check that against the patient's total PEEP. That's what we're looking at here. So make sure we keep not only the plateau pressure under 30, but also keep that driving pressure under 30. And then we need to adjust our ventilator settings to optimize to get the best out of our driving pressure. The minimum amount that we use, the better, the less stress on those lung units to allow them to heal. So identifying driving pressure. So those were the graphics that I showed it previously, but when we're looking at this, you need to do an inspiratory hold maneuver to measure the plateau pressure and record the set PEEP. and subtract the two. So the plateau pressure reflects the pressure inside the alveoli, the very sensitive parts of the lungs that we're looking at here, when airflow is paused at the end of inspiration. So this gives us a more accurate measure of true pulmonary stress than peak airway pressure. That peak airway pressure could include a patient having too tiny of an endotracheal tube or too tiny of a tracheostomy tube. Those things can cause that peak airway pressure to increase when it's actually not a stress on the lungs. It's just the conduit to get to the very sensitive parts of the lungs. So identifying and monitoring driving pressure really will help assess the patient's functional lung size, which is what we're looking at as their lung compliance. So we need to adjust our vent settings to improve the outcomes here. So ultimately, conduct an inspiratory pause, record the PEEP, calculate the driving pressure, and then do what you can to understand what could be causing this driving pressure to change. And I do have a compare and contrast slide to be helpful as well. So what can increase driving pressure? Usually it's associated with lung injury, and that's what we're talking about here with ARDS. A decreased lung compliance, like we see with ARDS, we can also see it with pulmonary fibrosis or pulmonary edema, usually requires higher pressures to deliver that same tidal volume. So if we give them that same tidal volume for a lung that's sick, that's supposed to be designed for a lung that's healthy using their predicted body weight, those tidal volume settings can elevate driving pressure if we don't decrease them. So if we don't decrease them, that leads to overdistension, and that could cause trauma because now we're overdistending and it's almost like a balloon about ready to pop. It's going to tear and rip and have those stresses that make it even worse. So the trauma to the lung gets worse. What about if PEEP levels aren't appropriate? If we use too low of a positive end expiratory pressure, if our PEEP is too low, then we're going to have alveolar collapse. And that's not going to be helpful because then it's only the alveoli that are open that are now getting overused, and that could cause stress on those as well as decreased surface area because you're not spreading that energy to the other alveoli. So now you're causing a lot of biotrauma and stress, or atalic trauma, if you will. What if our PEEP's too high? Well, that's another thing too. It can cause alveolar overdistension and stress and cause the patient's alveoli to have that barotrauma, that excessive pressure. And so we're looking at making sure we have the appropriate amount of PEEP, the appropriate tidal volume for what's going on with the size of the patient's functional lung. Not what their ideal body weight, their predicted body weight size is, but what the size of their lung is currently. And this is something that we have to change as the patient's lungs change in size. Let's say they're not as edematous or swollen, then we have to be able to reduce our PEEPs because the lungs aren't as heavy anymore and don't need as much pressure to maintain them, or increase our tidal volumes as the patient's allowing us to do so and to maintain the adequate pH and avoid underdistension and avoid atalic trauma. So we need to constantly be in that room when we're checking these patients to make sure that we're not causing lung stress every time we go see them. You can't just set it to a certain setting and call it good. Every time we're going in there, their compliance could be changed based upon their position. Are they prone? Are they supine? Are they left side dependent? Right side dependent? Are they in semi-Fowlers? Are they Fowlers? What's going on with their positioning? Is their chest wall abdomen changing things? Are they diuresing? Are they having less weight on their lungs? Are we giving them more fluids? Is their lungs gaining weight? Is their swelling getting worse? Their ARDS getting worse? Maybe they do need more pressures. So this is a constant dynamic relationship that you're going to have to look in when you're going into the room time and time again, is what's going on with their compliance? Is my tidal volume and my PEEP at appropriate levels for what's going on with this patient's lungs currently? Not what it was 6 hours ago, not what it was yesterday, but where is it right now when you're in that room with that patient? So what are strategies to reduce driving pressure? We've already talked about this a little bit here. So we need to optimize ventilation while minimizing lung injury. Sounds great, right? But how do I do it? The most effective intervention is usually reducing tidal volume. And this is what was done previously in the ARDS-NET study, where they took 12 mLs per kilo predicted body weight and 6 mLs per kilo predicted body weight, and they compared the two. And reducing tidal volume reduced driving pressure for sure, as well as the stress on the lungs. And so that's one of the things that really helped with the survivability in that model. So one of the most effective interventions is thinking about reducing the tidal volume. Understand by reducing the tidal volume that could cause for situations such as permissive hypercapnia or hypercarbia, and you might have to do more pH management. So reducing tidal volume is a practice that's supported by studies that really demonstrate improved survival rates in ARDS patients. That's considered lung protective ventilation. But another thing to think about here, options, is optimizing your PEEP settings to maintain recruitment. And so over-distending PEEP, right, using too much PEEP, and underusing your PEEP can also cause issues to this patient. When we optimize our PEEP settings, we're recruiting alveoli, we're spreading the pressures among all the different parts of the lungs. Not most of them, not every single alveoli will be open, of course, but we're spreading it among most of them and allowing for less stress on just a couple parts of the lungs, a couple areas, if you will, and we're not over-distending certain areas. So we're helping maintain that recruitment and that pressure and the oxygenation. But when we're doing this, over-distension can also be an issue. So just because a patient required a PEEP of 18 6 hours ago or 10 hours ago doesn't mean that they need a PEEP of 18 right now. If we changed positions, if we diuresed them, if their lungs are getting healthier for some reason or another, their inflammation's going down, whatever's causing their ARDS, their trauma's recovering, then maybe that PEEP of 18 now is causing overdistension and causing a dead space issue and causing more ventilator-induced lung injury. So this is where we have to look at this. Not only is a tidal volume an appropriate change, but also optimizing PEEP a thought as well. So if you go into a room and the patient's over-distended, that could be secondary to you using too much PEEP that's causing a reduced blood flow. Hey, what's a quick way that I know that my PEEP is too much or my mean airway pressure is too much for the patient? If you have end-tidal CO2 and you start to see it decrease compared to the PA CO2, that could be a sign that you're causing over-distension and causing a dead space. So turn down your PEEP. Try turning down your PEEP and seeing if that's the issue. If the end-tidal CO2 comes up when you turn down your PEEP, closer to what it was on your blood gas CO2, then odds are you were actually over-distending and causing a dead space issue. Little food for thought there. Ideally, we can try to look at other things to improve their lung compliance and resolve their pulmonary edema and reduce inflammation. Those are other thoughts there too. Some things that can help with their compliance could be position related. So when we're looking at these things, treating the underlying conditions that really impair the compliance will be very helpful. If they have a pulmonary edema component, are there treatments we can do to help their pulmonary edema? If there's an inflammatory process, are there things we can do to reduce the inflammation that would help decrease the driving pressure? These are just some things to think about. All right, what is driving pressure due to the lungs? A high driving pressure is very closely associated with ventilator-induced lung injury. So when driving pressure is excessive, the alveoli become over-distended. This leads to barotrauma and volutrauma. This causes mechanical stress on the lungs and triggers the inflammation. Yes, and this is known as biotrauma. And biotrauma will just exacerbate lung injury and make it worse and worse. A lot of studies have linked this elevated driving pressure to an increased mortality in vented patients. It included this Amato 2015 study. And so this highlights the significance and clinical practice of using driving pressure. So when you're going in to check on those patients, what is the driving pressure and how do I manage the driving pressure? Is it something as simple as reducing the tidal volume? Understand that could cause a change in your pH and your CO2 levels, or is it something like, hey, maybe this is a PEEP change? Something to think about. I like this slide when we're looking at this. So this is a way to look at, with my sources here, a way to look at driving pressure, things that can cause an increase in driving pressures. So the first one on the list is, of course, compliance. If they're going into ARDS, they have a pulmonary fibrosis, they have a pulmonary edema, optimizing PEEP actually might be a good way to start here to make sure you're recruiting the alveoli, but you're not over recruiting them. So using PEEP for the right levels should help, especially if you're using lower tidal volumes to also help reduce that stress on the lungs. Excessive tidal volume, especially if you're seeing beaking on that PV loop, or if you're seeing these other things where this patient's lungs are getting worse and worse, and where you're still using the same tidal volume, if their lungs are functionally getting worse and you're using the same volume of breath to deliver that to them, their lungs no longer functionally the same size it was 2 hours ago, 10 hours ago, whenever it was the compliance was better. So you might have an issue where you're causing overdistension. So reducing tidal volumes closer to that 6 ml per kilo predicted body weight might actually help prevent that alveolar overdistension. So really do think about the tidal volume if that could be an issue here. Just understand that could change your alveolar minute ventilation and cause your pHs to change. So watch your pHs after this. If your PEEP is too low, obviously, that could cause atelectasis and alveolar collapse. And so if we're able to recruit that, we're going to be able to spread that pressure over less areas. And so we're going to have a better driving pressure ultimately, because there's less excessive change. There's less pressure to overcome, just like blowing up that balloon when you first get it, where it's really hard to blow up because there's that very low compliance, nothing has been stretched out yet. It's going to cause a very high driving pressure. But if I have some sort of stretch beforehand, if I'm able to maintain a set pressure that keeps it somewhat open during end exhalation, then I can reduce that driving pressure. If my PEEPs are set too high, this is overdistension and causing volutrauma and barotrauma on my lungs, and that can easily cause issues where I'm trying to deliver breath when there's the alveoli are overdistended as it is. So making sure I have a PEEP that's not too high and not too low is important. Like I said, this could be something where just because the patient has a PEEP of 18 right now doesn't mean that it's not the same PEEP requirement that they'll have in 10 hours and 2 hours. That could change from time to time as you see the patient going through different positions and different interventions and where their disease is progressing. Is it progressing worse? Is it progressing better? And you're going to have to adjust those settings, the PEEPs and the tidal volumes, and look at underlying what is going on. Is this patient getting better or worse? Do they need a change in their driving pressure? And if they do, hey, which method is going to be best for this patient? Another one, just to be clear, is if they have inspiratory effort while they're spontaneously breathing. So that inspiratory effort can obviously change the driving pressure and all over the board. It can increase it, it can decrease it. So a method to do this would be to perform a neuromuscular blockade or sedation to help minimize this effect too if their driving pressures are excessive. So the study by Amato in 2015 really explores critical variables in survival rates in patients specific to ARDS. So it focused specifically on driving pressures during mechanical ventilation. And when we look at ARDS, it is a life-threatening condition, and there's inflammation and hypoxemia, and traditionally can require mechanical ventilation as a primary intervention for them. So this study really does emphasize that driving pressure is the primary variable that reflects the difference between the plateau and the PEEP, is a primary variable to determine survivability in ARDS. By analyzing data, they looked at multiple randomized controlled trials, and they tried to look at minimizing the driving pressures, and minimizing driving pressures significantly enhanced the patient's outcomes in this Amato 2015 study. So using mechanical ventilation strategies that use lower plateau airway pressures is a key thing. So this includes using lower tidal volumes and higher PEEPs possibly, or lower PEEPs. Like I said, optimizing that PEEP level for these ARDS patients. But the importance of each of the components of making sure their plateau is under 30, making sure their tidal volumes are low, making sure that we're using PEEPs that are appropriate for their functional lung size. How do we know which one's the best one? Well, they looked at compliance, and that's what the driving pressure is looking primarily at, is what's the compliance of the very small sensitive parts of the respiratory zone, and make sure that we target very low changes of pressure in that area. If we target very low pressure changes in the very sensitive parts of your lungs, then that will allow for the least amount of biotrauma. So we're looking at the functional size of the lungs. The Amato study, they hypothesized that driving pressure, when they're looking at the functional size of the lungs instead of the predicted lung size of a healthy person, would be more strongly associated with a survivability than just looking at tidal volumes being smaller or using higher levels of PEEP or lower levels of PEEP for these patients. So driving pressure, once again, is the difference between plateau pressure and PEEP. And as compliance decreases, there will be an increase in driving pressure. So as the lungs get stiffer and stiffer, it's going to take more pressure on the very sensitive parts of your lungs. Well, if you're doing more pressure on the very sensitive parts of the lungs, could that potentially cause issues? Absolutely, it can cause that biotrauma. I'm going to use more and more pressure on the very sensitive parts of the lungs. Well, I'm just asking for more injury there, right? So is the appropriate thing to keep using higher and higher pressures on a very sick lung, or is the appropriate thing to reduce that driving pressure on the very sick part of the lung to allow for that lung to not get worse with us causing more trauma to it, right? The ideal situation is to maintain or to allow lungs to heal without causing more harm in the beginning. So, driving pressure does play a significant role in determining outcomes for patients with ARDS, and the studies showed that lower driving pressures improve survival rates because excessive driving pressure caused ventilator-induced lung injury, and that was the Gagnone study in 2016. So this understanding really led to a paradigm shift focusing on instead of tidal volume, we focused on driving pressure as the key ventilatory parameter. So instead of just making sure we used small tidal volumes, now we're looking at driving pressure. So us, respiratory therapists, the clinicians, we need to adjust settings to minimize driving pressures to reduce the lung strain and overdistension, which is what the 2015 Amato study said. And if we target an optimal driving pressure threshold, we can balance oxygenation with lung protection. Because how helpful is it if I optimize oxygenation today, but I destroy the lung so bad that you can't oxygenate or ventilate tomorrow? So I need to make sure that I balance oxygenation with lung protection. Are their PO2 levels adequate? Are their SaO2 levels adequate? Right? Do they have the ability to maintain that pH that allows for survivability? Not perfect pH, but survivability pH. A sick person should have a sick blood gas, but survivable. A healthy person should have a healthy blood gas. So don't try to put a healthy blood gas in healthy vent settings on a sick lung, right? That's not going to work. You're going to cause ventilator-induced lung injury. So the Amato study used a statistical tool known as multi-level mediation analysis. I know, very fancy. And it looked at individual data from 3,562 patients with ARDS. So quite a big amount of patients enrolled with this. And they looked at 9 reported randomized controlled trials. And they looked at the change of pressure as the independent variable associated with survivability. That's why this changed from just using low tidal volumes or using different PEEPs. It changed to using driving pressure. So they isolated the changes in pressure resulting from ventilator settings while minimized the confounding due to the severity of the lung disease. So among the variables, driving pressure was most strongly associated with survivability. So that's the big one, right? That's the big thing to take home from this. And it was associated with increased mortality, even in patients that had protected plateau pressures and tidal volumes. Changes in tidal volumes or PEEP after randomization were not independently associated with survivability. They were associated if they were among the changes that led to reductions in driving pressure. So the big conclusion of this was that driving pressure was the ventilation variable that best mitigate risk. So decreasing driving pressure and changes in ventilator settings were strongly associated with increased survivability. So once again, it's not just using low tidal volumes, it's not just using low or high PEEPs, it's using low driving pressure to reduce lung strain. So driving pressure is an important part to look at, as you've seen already. Driving pressures increase the ventilator-induced lung injury and really exacerbate a compounding condition, a compromised condition. So you're asking a sick lung to do healthy tidal volumes. No, that's making it worse, right? You can't ask something that's sick and put more strain on it when it's sick. Could you imagine next time you get the flu and people asking you to do a bunch of things at the same time? You're going to make the situation worse. You need that recovery. And using low driving pressures while someone has a sick lung on a ventilator is going to be helpful to letting that lung recover without causing more biotrauma, without causing more stress and exacerbating the condition that they already have. So don't be a villy. Don't cause a villy, right? Reduce that driving pressure. So survival rates improve when driving pressures are maintained at low level, ideally below 15 centimeters of water pressure. Regardless of the ventilator parameters, the tidal volume or the PEEP, driving pressure is going to be the big determinant thing that this study looked at. So we need to target driving pressures and being more important than even adhering to strictly tidal volume or PEEP thresholds. So this reshaped the approach to ARDS management. In addition to driving pressure, the study examines other variables that influence survival, including plateau pressure. So PEEP, they looked at the compliance of the respiratory system, and plateau and PEEP have been usually the benchmarks of event settings, but the driving pressures offer a more comprehensive assessment of the lung stress and strain because it's under dynamic conditions. It's under the delivery of the breath. It's under the stress of breathing. So high plateau pressures and low compliance were associated with worse outcomes. But when they controlled for driving pressure, their impacts significantly diminished. So this ultimately underscores the primarity of looking at driving pressure as the modifiable risk factor in ARDS management. So how did they do this? Well, the study used a validation of a survival predictive model in ARDS research. So they used a retrospective data to help develop a test model that incorporates driving pressure as the key variable alongside more traditional variables. And by validating the model across multiple data sets, the authors really demonstrated that this is a very reliable and approachable for different types of patients with ARDS. So it's a predictive model that allows the clinicians at the bedside, the RTs, the doctors, anyone else at the bedside to estimate the survival probability and tailor interventions based upon the individual patient profiles. So this actually opened us up, instead of just saying give low tidal volumes, high PEEPs, it opened us up to understanding, okay, what is really causing this trauma and the stress that could be causing the situation to get worse because we want this patient to get better. How do we approach this in a way that will help that patient get better? So lung compliance was the vital role in determining driving pressure. The more stiff the lungs were, whether it's edema, swelling, fibrosis changes, those type of things, led to worse outcomes. So low compliance is a big thing to look at here. So as the lung compliance changes, and we're looking at static compliance, not dynamic compliance, but static compliance, the lower compliance usually indicates that the lungs are stiffer and harder to move. That means you need higher pressure to get adequate ventilation, which could cause ventilator-induced lung injury. So this study emphasized a lot of strategies aimed at improving compliance. So options here, recruitment maneuvers or prone positioning can reduce driving pressure and improve survival rates. So we can tailor vent strategies to optimize compliance, and that might serve as an adjunct to driving pressure management as well. So is there a positional thing? Is there something else that I can do, like using a recruitment maneuver to help optimize compliance and therefore reduce driving pressure, instead of just reducing tidal volume? So they built a good predictive model for survivability. And ARDS does require systemic approach. And so Amato in the 2015 study employed a regression analysis to identify independent predictors of survivability. So the model really was evaluated using metrics, and it assessed the accuracy and made sure that it decreased its discrimination. So it used cross-validation techniques that helped the model that was used become more robust, to become more reliable. So by testing the performance across different patient populations that have that ARDS, it really showed how predictive and how well done this information is. So what did they do to optimize the parameters? So they optimize its parameters. Um, this helps balance the complexity and the interpretation. So it included driving pressures as the central variable to improve the predicted power, without overfitting it, and that's a whole separate discussion. But we're making sure that this model that was used for the study remained clinically relevant and easy to implement in real-world settings, which I agree. This model is really easy to implement into the real-world bedside settings. So looking at compliance and plateau pressure is of physiological relevance and statistical significance, and this strengthened that this model's utility that they used to show that this is something that could be helpful to our patients at the bedside. So we need to make sure that this model is something that will apply to different types of patients that have ARDS. So it was tested in diverse patient populations from various clinical trials. And this was a pretty crucial step to make sure that there's no bias in a situation or limitation in one of the data sets or something like that. So by demonstrating the constant performance across multiple different cohorts, the study really established the model as a reliable tool for guiding ARDS management. So we need to still do ongoing validation as new data, new treatment modalities, new modes, new therapies emerge. We still need to do ongoing validation, but overall it was very diverse and that showed a lot of reliability and trust for this study. So how do we integrate this? It really advocates for a paradigm shift in ARDS management when it came out. So we prioritize driving pressure as the key therapeutic target, not just using tidal volumes that are 6 and under and high peeps. So it really helped make sure that that shift happened. So our therapeutic target when we're managing these patients is now driving pressure. And by integrating the predictive model into your routine clinical practice, you can adopt a personalized approach for ventilatory support that not only improves survival rates, but also minimizes the risk for long-term complications associated with ventilator-induced lung injury. In other words, you're not going to cause more harm as long as you're targeting low driving pressures. Well, that's the idea anyway. So the study by Amato really shows the critical role of driving pressure in making sure survival outcomes in ARDS are appropriate. They did a rigorous analysis and validation, and they really did establish that driving pressure is the big modifiable risk factor and the central component of survivability in their predictive model. So This whole thing highlights the importance of personalized ventilatory strategies and account for individual patient characteristics. Maybe this patient has a morbid obesity and the higher PEEPs would be more appropriate. Maybe this patient is more underweight and maybe the PEEP is too high and over-distending, and that could cause an issue. Maybe this patient does have a smaller functional tidal volume size. Let's go ahead and use that smaller functional tidal volume size so we can customize it more to these patients to account for individual characteristics. And this really did pave the way to improve outcomes in ARDS management. So we still need to continue to research and do innovation in predictive modeling to help refine things, but this was a big landmark study. What were some limitations? Got to be thorough here. Limitations of the study. It showed compelling relevance for the role of driving pressure in ARDS, but there are certain limitations that they have. It was a retrospective study, so that can introduce potential biases. The findings may not fully capture the complexity of individual patient responses. Also, the model's reliance on driving pressure assumes accurate measurement and interpretation. In other words, is it the same therapist, the same pulmonologist, is it the same person doing the plateau pressure maneuvers? How long are they holding the plateau pressures for? How are they using PEEP total? Are they using the set PEEP? Are they right? So there's some variances that can be there across different clinical settings. So in future studies, they should really look at addressing limitations and look at standardized measurement protocols moving forward. So practical applications, hopefully you see some practical applications with this. It allows us to really stratify patients based upon the risk of mortality and tailor the ventilatory strategies accordingly. So I can know on this patient, they might do better from a tidal volume change than a PEEP change. On this patient in the next room over, they might do better with a PEEP change than a tidal volume change. The next room over, they might do better with a higher PEEP versus the patient in that previous room. The patient went over from there that has ARDS might do better from a lower PEEP strategy. So patients with high driving pressures may benefit from different types of interventions, but the point is to look at those driving pressures and to minimize those driving pressures to reduce biotrauma. So patients with high driving pressures might benefit from more aggressive interventions as well that aim at reducing stress. Another option to think about would be ECMO, right? Is this something that would help reduce stress and using personalized vent settings for that type of situation? So this model not only was great for looking at how we do ARDS management with mechanical ventilation, but it's a framework for future research, which includes exploring additional variables and interventions other than just doing what status quo currently is. All right, important takeaway time. Given its impact on the patient outcomes, driving pressure is a focal point in mechanical ventilation management. So the research does suggest it's a better predictor of survivability than traditional parameters, such as looking at low tidal volumes or high PEEPs alone. So ventilator protocols should emphasize maintaining driving pressures below 15 centimeters of water pressure to reduce lung injury risk. And this means that we need to continuously monitor and adjust our vent settings. So that's where knowing what's going on with your patient and you being that professional at the bedside can help out with understanding what's causing the driving pressure to be high in the situation. And so we need to be able to see those things and make appropriate suggestions and interventions to improve this patient's survivability and minimize complications associated with mechanical ventilation. So driving pressure is a vital parameter in mechanical ventilation, and it directly influences the stress of the lung and the patient outcomes. So every time you go into that room, the patient's lungs and their outcomes, their survivability, are dependent upon that driving pressure, and that's what the evidence-based medicine currently says. So we need to identify and monitor our driving pressures, and we need to make sure that we're adjusting our vent settings effectively to reduce the risk of ventilator-induced lung injury. That biotrauma can make it worse. So if you understand the factors that contribute to an increased driving pressure, which I went over into this lecture, then in implementing these strategies to help lower driving pressure, you can optimize mechanical ventilation to improve survivability on your really sick, your critically ill patients. So we still need further research to improve and refine the ventilation strategies, but ultimately this driving pressure was a key point in paradigm shift. All right, this is the part where you can pause the video and look at all these sources, but hopefully you got something out of this, and thank you for listening.